This webinar is brought to you by IPSA support for International Thyroid Awareness Week 2023. Before we begin, we'd like to thank our sponsors, Merck, Exelixis, Ipsen, Immunovant, and IPSA. And without further ado, here is your host, Ashok Bhasin, President of Federation Thyroid International.
Welcome to the third annual public lecture. My name is Ashok Bhasin. I'm the president of Thyroid Federation International, a global thyroid patient organization. This is the 15th year that we are celebrating the International Thyroid Awareness Week. And people are tuned in from Australia, Europe, Asia, and also in North America. So welcome all. Welcome to the 15th International Thyroid Awareness Week. We've been doing this on different topics for each year. This year is thyroid and genetics. And not everything that you hear today is going to be on thyroid and genetics, but on 27th especially, there is going to be a big section on thyroid and genetics. I will ask Jamie to give the details about the protocols. And then I will introduce the speakers. So Jamie, over to you.
Thank you, Ashok, and welcome everybody. If you have any technical difficulties over the course of this webinar, you can contact the support team via the means displayed on the screen below. These contact details will also be easily accessible from the chat box of this webinar. For those of you outside of the European zone and who want to avoid exorbitant telephone fees, the phone number is available through WhatsApp as well. The support team will do their absolute best to assist you in anything you'll need. Without further ado, I'll let Ashok take the floor once more. Goodbye.
Now I would like to introduce the speakers, and I would like to introduce Dr. Laszlo Hegedüs. Dr. Laszlo Hegedüs is Emeritus Professor, past President, ETA, as well as Danish Thyroid Association. He's from the Department of Endocrinology and Metabolism, Odense University, from the University Hospital of Southern Denmark, Odense, Denmark. Dr. Laszlo, I'm really very thankful to you and also to Peter. Peter is one of our own, and Peter is treasurer of Thyroid Federation International and very closely associated with Empathy Survey. So welcome both of you, and over to you, Dr. Laszlo and Peter.
My name is Laszlo Hegedüs, and I welcome you to this webinar on patient-centered approach to hypothyroidism. It will actually be an introduction to a dialogue with Peter Lekvik from the Thyroid Federation International. So it's just a pitch to him, viewing some of the issues that may prone him to ask some relevant questions for the patients. Personally, I'm a former president of the Danish as well as the European Thyroid Association and have worked with thyroid patients for approximately 45 years. So that is my background. Of course, I have some disclosures, the most important ones being that this is generously supported by IPSA, but also that I haven't used any kind of artificial intelligence in the preparation of this talk. So these are my own opinions. One can always ask whether it is very important, whether it's worthwhile to have a diagnosis and what the price of having a diagnosis is. We as physicians often feel that patients are very knowledgeable and they put pressure on us in a way that we always seem to be lagging behind. And this will be evident from my talk. So sometimes I felt like Charlie Chaplin in modern times. It is true that the reason for dissatisfaction amongst patients with hypothyroidism might be based on the fact that we diagnose more and more people, that we have lowered the threshold for making the diagnosis, and therefore, of course, have a number of individuals who have very mild disease and could potentially have other causes for their satisfaction or dissatisfaction with treatment than the one linked to having a diagnosis of hypothyroidism. Here you can see over the last couple of decades how much the prevalence of thyroid disease, of hypothyroidism, has gone up. When we ask physicians what they think the reason is for persistent symptoms in individuals who are euthyroid but have the diagnosis of hypothyroidism. It's interesting to see that the physicians point at three major causes being psychosocial factors, comorbidities, and unrealistic expectations, while the least important in the eyes of physicians seems to be to the right, physiology, that is the need or the lack of having adequate amount of thyroid hormones in various parts of our bodies. When we asked the patients, and this is what we did in this so-called empathy study, that is the impact of hypothyroidism on satisfaction with care and treatment and everyday living, then the picture is somewhat different. The patients perceive that the low levels of satisfaction with care and treatment for hypothyroidism are strongly associated with negative experiences with healthcare professionals. That is, not having access to the relevant healthcare professionals, having too little time, and having a poor dialogue and too little information. So this is very much different. When we did the thesis, which is a bit different from the empathy, because empathy was focused on the views of the patients, while thesis is focused on the views of expert physicians all over Europe. We interrogated or asked via a questionnaire all specialists in endocrinology via the endocrine societies in 28 countries what their views were in relation to a number of questions related to management of hypothyroidism. This was done a few years ago, and it was very interesting that the conclusions from these pan-European surveys of physicians, expert physicians, was that the treatment of choice for hypothyroidism is levothyroxine in all European countries, and that desiccated thyroid extract therapy is deemed as inappropriate, and as is combination therapy with T3 and T4, which is rarely used. So this initiated some thoughts that materialized in a study called Empathy, the E-mode patient self-assessment of thyroid, so thyroid disease and thyroid dissatisfaction. And this was a combination of 4 expert physicians in the area collaborating with Thyroid Federation International, here represented by Peter Lackbrick, and the Picker Institute, experts in constructing such questionnaires and generously sponsored by IPSA. This reached approximately 4,000 individuals in 68 countries. And it showed, much to our surprise, that from these respondents, it was clear that 16% of them actually did not have the correct diagnosis. They were put on thyroid medication despite never having been hypothyroid. You can also see that approximately 35% had very mild hypothyroidism and 48% more advanced, more clinically overt hypothyroidism. And if you look at the consensus among specialists, we only agree that patients with overt hypothyroidism for sure need therapy, while it's very questionable whether there's an advantage to treat a number of the individuals in the subclinical part of this table. First of all, based on prospective randomized studies, not being able to show that treatment of subclinical thyroid disease changes quality of life. It's interesting that amongst these respondents, these 16%, 1/3 or 31% in this euthyroid group had persistent symptoms on levothyroxine. So when asking what the principal reason was for these individuals to switch from levothyroxine to a different formulation, you can see that 1/3 of these individuals offered the reason to be persistent symptoms on tablets of LT4. So there may be a number of reasons for persistent symptoms in patients who have the diagnosis of hypothyroidism, but have are dissatisfied with their quality of life. And I've just listed some of these. Of course, it could well be that in some areas there is insufficient conversion of T4 to T3. It could also be that a number of these individuals have multiple comorbidities. It's not unusual for patients with hypothyroidism to have other diseases that may explain the lack of adequate quality of life. Also, the potential for an autoimmune inflammatory reaction in the brain has proponents. It could be the wrong diagnosis, as I've just shown, and it could be the issue of somatic symptom disorder. And we'll focus a little bit on this. So somatic symptom disorder is defined as persistent unexplained symptoms associated with significant functional impairment, psychological distress, and high healthcare cost. That is, symptoms that are not easily tied to hypothyroidism, but where the patient feels that there's a connection between the two. There are a number of investigations. Unfortunately, until now, there have been no such investigations in the thyroid field, but in a number of other situations, for example, amongst patients in primary care, this is well investigated, and it occurs in up to 40% of such patients. It is thought to be associated with personality traits and usually starts before the age of 30, that is long before the diagnosis in hypothyroidism in most of our patients. The questionnaire, the PHQ-15, has 15 questions, and you're supposed to answer these as not bother at all, bother a little, or bother a lot by these particular questions, one being stomach pain, another being back pain, trouble sleeping, etc. And if you score above 10, it means that you're positive for somatic symptom disorder. So what did this investigation then show in the empathy study? How common is somatic symptom disorder among hypothyroid patients? And here you can see that amongst our empathy participants, 58% qualified for this particular phenotype of somatic symptom disorder, while this was only 7% in the background population, which was age and sex matched. So are these persistent symptoms then more common in hypothyroid patients with somatic symptom disorder than in hypothyroid patients without somatic symptom disorder? And here you have the answer. That is certainly true. From this, of course, we automatically wish to know whether hypothyroid patients with somatic symptom disorder attribute persistent symptoms to hypothyroidism. And here you have the data. Here you have individuals with and without somatic symptom disorder, showing that this is much, much more common in patients who have this particular phenotype. So this may lead to some kind of conclusion, or at least some speculation as to the potential mechanisms here. So euthyroid people with hypothyroid-like symptoms may be assigned a wrong diagnosis, leading to the wrong treatment, levothyroxine, which then doesn't help the individual because the issues are not related to hypothyroidism per se, and this means you will still have persistent symptoms. Again, a speculation. It could also be that hypothyroid patients who have the diagnosis of hypothyroidism are euthyroid, but have the somatic symptom disorder feature. They are also given LT4 or other drugs, but which is not helpful because the symptoms are not due to hypothyroidism, but to other issues. Now, going back to our 4,000 respondents in the empathy study, it was also interesting to see that, of course, some were not satisfied with the treatment. We saw that. And trying to understand what happens with these patients, one view could be, so are individuals on levothyroxine tablets then changed to other formulations, for example, T3, the combination of T3 and T4, or maybe desiccated thyroid extract. And our view was that we thought that there was a risk of this leading to overuse, to abuse, and to having another disease that is hyperthyroidism. And this is what we could demonstrate, that amongst those who were on T4, only 10%, 9.5%, were overtreated with a suppressed TSH, while this was the case in 41% of individuals being on the alternatives T3, T4 plus T3, or DTE. So in real life, many patients on T3 or combination of T3 and T4 are simply overtreated, either by their physicians or by their self-medication. So my conclusions from this introduction would be that most patients have satisfactory quality of life on tablets levothyroxine, but 10 to 15% remain symptomatic. This is due to a number of factors, including, of course, inadequate thyroid hormone in certain areas of the body. I think this is the few individuals. Wrong diagnosis, that is not having hypothyroidism at all. Comorbidities, other diseases that are responsible for the symptomatology. It could be over or under treatment of the hypothyroidism. And finally, we suggest that it may also be related to the personality that is suggestive of being prone to dissatisfaction, as shown by the somatic symptom disorder questionnaire. So, should we accept this? Should we interpret this? I think we should. We should accept that symptoms are there when the patients say they have symptoms. We need to offer explanations for the fact that many may not be due to hypothyroidism and therefore cannot be cured by any type of thyroid hormone. How to help in this situation is a challenge, and of course demands individualized management. This is the hard part. And let me pitch the following to Luca Bolentini, who will talk on social media and web not so long from now. And I think his poem-like expression here is very wonderful. So Gustave Le Bon, who was the founder of modern mass psychology, and not Luca Bolentini, but Gustave Le Bon, who said the following: the masses have never thirsted after the truth. They turn aside from evidence that is to their taste, preferring to deify error if error seduced them. Whoever can supply them with illusions is easily their master. Whoever attempts to destroy their illusions is always their victim. With this, I thank you for your attention and look forward to the dialogue that will revisit some of these issues. Thank you very much.
Okay, Laszlo, very, very interesting talk. It brought me to some questions, and one of the first questions that comes back every time for us as patients, Hashimoto and hypothyroidism, is that the same?
Well, most patients with Hashimoto's disease certainly have hypothyroidism. But of course, you can have chronic autoimmune thyroiditis, which many often call Hashimoto's disease, although they're not hypothyroid. I think the easiest way to explain is that hypothyroidism just means that you have a low metabolic condition, and that some of these patients have Hashimoto's disease. It's the vast majority of patients with hypothyroidism who have Hashimoto's disease or chronic autoimmune thyroiditis. Approximately 85%, but it can be caused by other issues, just like surgery. It can be caused by being treated for hyperthyroidism and a number of other more rare diseases, conditions such as congenital hypothyroidism, but the vast majority have Hashimoto's disease.
Okay. That brings me to another question. You mentioned unrealistic expectations. I think that a patient that goes to a doctor has the expectation to be cured, and the doctor that treats him or her can put levels into that. Why do you think that people have these unrealistic expectations?
Because, well, I think it's a wonderful question because it's it seems like, the impression could be that the physician just wants to get rid of the problem, and it's an easy way out, saying that the patients have unrealistic expectations. But there have been a number of investigations into this, for example, also in Denmark, showing that 35% of the population participating in such questionnaires were dissatisfied with their quality of life. So this is a background for many in our communities. Now, if you're assigned a diagnosis based on very slim evidence, if you have a diagnosis, you carry that diagnosis with you, but you also carry your personality with you. And most physicians and most patients would like to tie the two together. So if you have a diagnosis, there's a tendency to assign this diagnosis as being responsible for whatever happens to us. And imagine, as I've shown you these data, that you're assigned the diagnosis of hypothyroidism, which you don't have, but your physician has been pressured by the patient or pressurized by their own ambitions to get, say, well, the patient has an issue, it's compatible with hypothyroidism. The biochemistry is not all that convincing, but the patient has symptoms and wants treatment, and then you offer treatment. How in the world could we imagine that treating somebody for something that they don't have will help, other than a placebo effect? So some will, of course, find this very nice, especially if the physician is nice, takes care of the patients, gives good information. But this is the wrong way to go to treat anybody for something that they do not have.
I think that's part of the whole problem in healthcare nowadays, that the cost of healthcare is so high that we have to consider what has to be done, and that takes time, and time is expensive, and many treatments are cheap. So also in this case, levothyroxine is just a couple of cents per tablet. So that's one of those things.
But Peter, just let me not interrupt you, but let's bring this cost to a higher level. If a number of individuals are changed, as I just showed you a slide of, are changed from levothyroxine to a combination of T3 and T4, and 40% of them in this questionnaire were overtreated, then it's not a trivial issue, because it's not the price of the thyroid hormone. Now it's the price of the additional disease and the shortened life that is at stake. So to me, as a physician, the most important is not to do any harm. I'd rather have a very long conversation with the patient telling that this is not the right way to go than offering something that I know will lead or can lead to abuse and prolonging misery, because it will, in the long run, offer comorbidity and shortening of life. So then it becomes very expensive.
I fully agree with you. Expenses, certainly in a political way, are viewed on the short term. And a patient should be looked at the long term, because a patient develops, and if a patient develops in the wrong way, then the costs only get higher. Like you say, wrong diagnosis is just putting more expenses to healthcare. There is another question. Somatization. You explained that somatization is part of dissatisfaction of patients, but is that then just between the ears of the patients, or should a patient then be treated for something else?
I think there are two questions in what you're asking. And let me start with the fact that any patient who has a complaint needs to be taken seriously. Now, taking a patient seriously is to try to find the correct reason for this dissatisfaction or low quality of life. It's not to get rid of the patient by assigning a diagnosis and giving a treatment that will give you peace for some months or maybe for eternity. It's really a question of understanding, making the patient understand that there may be, that can be very complex in a number of individuals. I'm not saying that somatization is the cause of dissatisfaction in a particular patient. What we have shown is that there is an association. It seems that if you have this personality, you are more prone to dissatisfaction than if you don't have this personality. But it can be a conglomerate of various factors that boil into this. So how much is based on having some somatic symptom disorder? We do not know. That would demand a randomized study, looking prospectively at this. This is cross-sectionally looking backwards. So we certainly cannot know. But this is part of revealing the many faces of individuals with hypothyroidism who do not feel adequately treated. And this means that we have also to look elsewhere than combination treatment with T3 and T4, or looking for any kind of other formulation of thyroid hormone. It just adds to the picture. It's not an either or. It's all of this that needs to be taken into consideration. So we just revealed another layer. It doesn't mean that the patient is crazy, if that is your question to me. Not at all. And you cannot change your personality. It is as it is. But you can change the physician's attitude. We need to understand how to help individuals who are not helped with levothyroxine. I hope this is clear.
It's clear to me. The question that comes up with me is, have you looked at the difference in satisfaction between the countries where other treatments like combination therapy or NDT, DT is allowed, and those countries where it's not allowed?
Yeah, so we're currently conducting such an investigation. I do not have the data. In most countries, this is not used. DT is not used, with an exception, and that is Canada, where we're performing such a study. So I would rather not talk too much about this because it might influence the questionnaire that is distributed. But very interesting. So let me translate your question into another scene that we can respond to, and that is is there geographic variation in dissatisfaction, independent of what is available, whether one is available or not. And that is very interesting, that it seems, and this is something that we're currently will be publishing very soon, so I will not reveal too much, but there seems to be a gradient with more dissatisfaction in countries that are more affluent and in countries that have more private practice taking care of these patients, which to me is very interesting. So if you live in Eastern Europe, you have less dissatisfaction than if you live in Northern and Western Europe. So it seems that being in affluent societies where there's more access, and maybe your level of satisfaction, dissatisfaction, is at a different point than in areas where you have much more complicated lives. I'm quite sure that if you did such a questionnaire in Ukraine right now, the dissatisfaction would drown in other reasons for having a miserable life. Sorry for bringing this up, but just to give an example. So I think this is very important.
It's very true that also the personal situation of a patient influences what he or she feels. If there has been a death in the family, then the feeling about the thyroid disease is completely different than in a more stable situation. Talking about stable situations, completely different area is pregnancy. Are there risks connected to taking additional products like iodine during pregnancy?
Well, this is really a tough question you found there, Peter. Of course, pregnancy is different. When I talk, whatever we've been talking about now is not related to pregnancy. It's related to the non-pregnant situation. In pregnancy, of course, it's very important to have a normal thyroid function. It's important for the ability to become pregnant. It's important for the pregnancy, for the child, etc. And there are tons of investigations, and we could use all day discussing this. But if we boil it down to whether one should give nutraceutics, for example, should we give iodine? Well, the answer to that would be that in countries where iodine supplementation is either done or there's abundant iodine in your food and in your drinking water, there's no reason to give extra iodine. But there are a number of countries where this is borderline, and it's been much discussed also in Denmark. It seems that we're still borderline in relation to at least the immigrant population seems to have a bit of low iodine in this situation, and there it may be very useful to give it. Another discussion has been selenium. Should we give selenium? And again, if you do not have an inadequate supply, then there's no reason to do this.
The question that comes up in this, and it's not so much question, it's more something that I see, is that like with levothyroxine, there can be overtreatment just because of, there is a need according to the internet. That brings us also to the next presentation, where internet and social media are mentioned. A very personal question to you, Laszlo. Do you use social media?
Well, that is certainly a personal issue. I use social media with my grandchildren, with my wife and my children, but otherwise, no. I will absolutely understand that there will be heavy critique of what I have said now. It will, of course, not affect me all that much because I do not use social media to see what patients think about me. So the answer to that is no. And I'm very happy with using trustworthy media rather than having all kinds of voices polluting my everyday life. Sorry, that's who I am.
Or that's nothing to be sorry for. It is a very good conclusion for this meeting. I am very satisfied with your answers. Of course, there are many more questions that I can give, but we will come back to that. In other situations, we see each other.
So let me thank you, Peter, for allowing me to be part of this, which is mainly a TFI organized meeting. And it's been very, very fun, very nice, very illustrating that patients and physicians need to work together to solve this issue. There's so much to do. The more we study this issue, the more questions we have. So thank you very much.
Thank you, Laszlo. We are very glad with your contribution.
Welcome back to International Thyroid Awareness Week 2023 program. And on our second series of lecture, we have Luca Bolentini. Luca Bolentini is from IQVIA. IQVIA is a company which specializes in data and what inference we get out of data. So they are in pharmaceutical data. They do all sorts of things regarding how much drugs are being used, how much patients are using, and which company, which product, etc., which area, what drugs are being used by patients. So there's a lot of information. There's a lot of statistics that IQVIA generates, the data they get directly from pharmacies, and they are also into consulting. So Luca is going to talk about strategy and innovation. He's from Educom, which is a part of IQVIA business in Milan, Italy. So welcome to you, Luca, and look forward to some insights from you. Thank you, and over to you, Luca.
Hello, everybody. It's a pleasure to be here to take part to this event. My name is Luca Bolentini, and I am Multi-Channel Strategy and Innovation Lead Manager at Educom. Educom is an Italian IQVIA business focused on developing digital initiatives for patients and for doctors in healthcare. And today my contribution will be about the relationship between digital and patients. It was already mentioned how the use of digital in healthcare could be conflictual. And I think that as a fact, the use of digital has been rising in the last years, both by patients and by doctors. If we have a look at some figures, we can see that it seems the majority of patients use digital, especially at the beginning of the information journey. And they use digital in addition to search for information about the healthcare providers. So they need to understand what is the opinion of the other patients about the specific hospitals or the specific doctor. And in this slide, we have added a few additional uses of digital in healthcare. We think that the patients use digital to search for emotional support, and they search for information about what other patients are experiencing or experienced in the past. In this informative journey, we can see that we have identified 4 steps. And in the first step, in the awareness step, patients search for especially symptoms using different sources, such as talking with friends, family members, or just having a look at the social media or digital sources. In the second step, they decide if they want to proceed with self-diagnosis, or maybe if they want to consult an hospital or a doctor. In the first step, when the diagnosis is get, they continue to autonomously to search for information, maybe using some sources such as digital sources, for instance, or maybe they continue to ask for details and information to their healthcare provider. In the last step, when the treatment is ongoing, they can search for different kinds of information. They search for emotional support, they search for practical support, or maybe they search for a second opinion, because maybe they could not trust so much the current doctor they have. In my opinion, digital social media come to play, especially in 2 different steps: awareness and post-diagnosis. In the awareness step, when patients search for symptoms, search for information about the disease, search for diagnosis, and it is clear that there is a risk in digital, because digital can offer so many resources that sometimes it becomes difficult for the patient to understand what are the right sources, what are the reliable sources. And this word, infodemic, I think it clearly expresses how an excess of information at the end of the day would not be a real benefit for the patient, because patients could be tempted to make a self-diagnosis, or maybe they could convince themselves they are affected by a specific disease. I agree with what emerged during the discussion between Professor Hegedüs and Peter Lodwig, because digital provides so many resources that people tend sometimes to search just for confirmation of their expectation. They have a suspect and they want to find the confirmation of a suspect on websites, on blogs, on social media. So it's a risk about the desire to search just for the diagnosis at any price. I think we have to consider an additional point, because patients search online, on social media, on digital sources, also because digital is easy to access. Digital is always available to provide feedback, to come back with some information, with materials. And this is not possible for doctors and for hospitals to be always available, to always be ready to come back to the patients with a feedback, because doctors don't have enough time to talk with all the patients in line with the desire of the patients. And so patients look at digital just as an answer to their anxiety, because they are able to get a quick and immediate response. Patients have the right to search for information online or on different sources to learn more about their disease. But it's important to offer patients all the resources to learn how to search online, how to filter information on digital arena. But patients, at the same time, should keep in mind that they need to talk with their doctors, to share their doubts with the doctors, because only the doctor knows the personal history of each patient, and only the doctor knows what is good and what is not good for each patient. At the same time, doctors have generally a difficult relationship with digital and social media, because they obviously don't like to compete with Dr. Google. They can get frustrated when the patients come back to them with some information or materials they find online, materials which, in a manner of speaking, could put in discussion the authority of the doctor. But doctors have to understand that they cannot be just the only point of reference for the patients, because patients want to share their experience with other patients, want to talk with other people who deal with the same challenges every day. And doctors cannot fully understand the difficulty of the life of the patient, because doctors are not patients. And so patients look at social media to answer this specific need. In my opinion, digital is good at providing first-level information about the disease, about symptoms, about treatment steps. It's good at providing emotional support because it gives the framework where the patients can discuss, can share their feelings. And digital is good at providing practical support, so information about the rise of the patients, information about the cost, the medical costs, and so on. In this context, all the actors engaged in healthcare, scientific society, pharma companies, patients associations are invited to develop and to build digital resources which can be considered as reliable by the patients and by the doctors too. I don't think that currently digital is the right solutions to make diagnosis or to manage the pathology, because digital can provide general information, but maybe it's just the doctor who knows the history of the patients and can provide the right path to each patient. How to build a responsible use in social media? The premise is that social media cannot be fully controlled, because it's impossible to remove or to avoid all the fake news available on the digital arena. But it's possible to support patients to develop specific skills in understanding how to identify what are the evidence-based projects, what are the reliable projects, and in this way, physicians should feel free to invite patients to access to reliable resources where patients can get information which are trustworthy. Patients should have the chance to freely talk with other patients within reliable frameworks which could be put at disposal, for instance, by established institutions such as patients associations. And as the last point, a physician should accept that digital could be an ally in building the therapeutic alliance. So physicians should understand that sometimes patients cannot maybe get all the information they try to transmit them, and maybe patients can look at social media to find answers to other needs the doctors cannot fully satisfy. In this last slide, we have tried to draw an ideal, responsible, informative journey. Obviously, it's an idealized path, but I think it gives an overview about how the digital could support healthcare. At the beginning of the journey, we can imagine the patient searching on Google about symptoms of the disease, for instance, and as a list of resources identified, and the patients should have the skill to understand what are the evidence-based projects and what kind of resources can be trusted. And then these resources should address the patients to the right specialist able to provide the diagnosis, to manage the treatment. And when the treatment is ongoing, patients could access to social groups, through digital resources, to share their experiences, to talk about their feelings, to talk about their emotions, to talk about everything maybe the doctors is not able to fully understand. And in this case, digital could be a good resource to find information, practical information. I know that it's not easy to build such an informative journey, but I think this mission should be accomplished by all the actors engaged in healthcare, pharma companies, patient association, doctors, patients, scientific societies. All these actors should have the ambition to understand how digital could really support the quality of life of patients and the daily activity of the doctors. I hope to have given you something to think about the next time you are searching on digital, on social media about your health. And I thank you for your time and for your attention.
We have now come to the conclusion of lecture series on 15th International Thyroid Awareness Week. I would like to thank Dr. Laszlo Hegedüs, Peter, Luca, and also Jamie Nisbet, who has put this webinar together. Thank you very much, guys. And on the other hand, I would like to also thank our sponsors, Merck, with whom we have been doing this for the 15th year in a row, Horizon, IPSA, Exelixis, Aminovant, and Ipsen, for their support towards Thyroid Federation International, for making it possible to commemorate the International Thyroid Awareness Week. Thank you very much, and see you guys on 27th. Don't forget, we have a very interesting lecture on thyroid and genetics by Dr. Alexandra, and some of the lectures were by Dr. Melos from Serbia. So looking forward, and look forward to seeing you on 27th. Bye for now.